very much, Tony. I'd like to talk to you today and was invited to talk about a special initiative that has been an undertaking both from the very talented staff of the Pricing Authority and our staff at the Performance Authority about a report that was released about 1 month ago. But I wanted to start actually with a couple of slides to talk a little bit about context, about the future of healthcare as we can understand it looking at data from yesterday, and how that information about how we have been performing in the past might help us in terms of creating and supporting a vibrant healthcare system for the future. So right across the country, Australia's health system is really considered best among the world. We're among the healthiest people, and in fact our spend on healthcare more broadly is really modest relative to other countries. But at a time when health spending is rising internationally, but there is a tremendous slowing in the growth of those expenditures, the pressure is on for both public and private funders, our health administrators, and our clinicians to ensure sustainability and value for money. And we can do that in a number of ways together, looking at issues of access, and we have a portfolio of products from the Performance Authority to help ensure that we're seeing the right people at the right time. Portfolio of products around quality of care, because we do know that poor care in many instances is much more costly than good quality care, but also looking at how to deal with the pursuit of efficiencies where we see stabilization and growth of expenditures. It wouldn't surprise you from the newspapers that we've been reading over the last year or so in Australia, most acutely in the last number of months, 6 months or more, that over the last 5 years we've seen tremendous growth in expenditures, but those expenditure curves are flattening in Australia and in fact in many other countries. Similar experiences occurring, for example, in France, UK, Netherlands, and so on. Our annual health spend more recently is still increasing at 1.5% in 2012-13, tremendously down from a 7% growth in just before 2009. But these shifts in spending, you can see right across countries, are much more acutely noticed when you consider it relative to shifts over time in GDP over the last recent years. So Australia is not alone and in good company internationally in the pursuit of strategies around access, quality, and efficiency to continue to support a vibrant and responsive health system. Excuse me. However, focusing on national statistics alone encourages us to view our health systems as really monolithic entities that provide uniform care. The truth is, however, that each of the nation's hospitals and local health systems deliver a variety of experiences to people in Australia. In Australia and elsewhere, some hospitals are working indeed much more efficiently than others. And the trouble is, until now, these national statistics really haven't allowed us to look at the performance of individual hospitals and local health services to see where efficiencies are existing, where we have opportunities to learn. So the National Health Performance Authority in the last 2 years has produced a number of reports about local health systems. We have information around access, quality, and efficiency of local health systems. For example, more than 130 measures of health and care and system performance across more than 300 local units of geography across the country. And we've been releasing reports over the last 2 years about the performance of our hospitals on issues of access, quality, and efficiency. The reports are very, very graphic in orientation, as are our websites, in acknowledgement of the fact that we know that people are very time poor and rich information systems need to be structured in such a way so that you can learn at a glance where indeed there are opportunities for us to learn from each other across the nation to improve care from patients and local communities. Where I'd like to spend the rest of our time together in this presentation is really on a most recent report done, as I mentioned, as a, building on the talents and expertise and huge advances in methodology from the work that the Pricing Authority has undertaken over the last number of years, in tandem with our staff, to produce a report, unprecedented as I understand internationally, that compares the relative efficiency and cost performance of more than 90 public hospitals across the nation. This report shows for the first time which of Australia's largest public hospitals have the lowest operating costs for admitted patients and which have the highest costs, through national work that took us approximately 18 months to look at comparative costs right across hospitals. The differences indeed are considerable right across the country. Costs for providing similar services to similar types of patients can be nearly twice as high in one major metropolitan hospital as an example compared to another. Also possible with the report, of course, is to look at smaller hospitals, medium-sized hospitals, and across metropolitan and regional areas. So a couple of points just on methods, and by all means, I would encourage you, those interested in much more about the report and its design and methods, to attend a session that's on Friday on the concurrent session 8, where my colleague Dan O'Halloran, who led this report, will be describing in detail the methods and our conclusions. The report, though, from a high level, really took us 18 months of developmental work with extensive work, as I mentioned before, with the Pricing Authority. The report was overseen by 3 advisory committees, one that was experts from jurisdictions, another from stakeholders, heavily loaded that committee with clinicians and people who worked in hospitals in local communities right across the country, and some fantastic ideas around where the report's conceptualization and design came from that, and I'll show you in a few minutes. The third report was, third committee was very big, actually, with technical advisors who knew a lot about data and a lot about measurement, particularly in this area of relative efficiency. We also relied heavily on independent reviews that had been commissioned and conducted historically by IHPA to understand where we had national consistencies or inconsistencies in the costing information across our hospital, and we used that information naturally to design the methods to support fair comparisons. We also heard from clinicians about the comparing the operational costs just for admitted patients, which I'll show you in the next slide, why we ended up using 2 measures of relative efficiency in the hospital. And quite frankly, after 6 or 9 months of work, we landed where Tony told me we would land in the first place, that it didn't matter how you measure, the results were the same. But like I say to Tony, we didn't know before we started, but he was right. But we did it anyways. Okay, so what were the 2 measures? One is cost per national weighted activity unit, which I won't go into detail, particularly with this audience, but really looked at the operational costs. So we pulled out infrastructure costs, and we also pulled out some of the costs that were deemed non-comparable, just based on our information systems across the country. Leaving, a residual for us to compare a residual amount of costs to compare hospitals that is a bulk of the operational costs for similar patients for similar procedures. The second measure that we did was upon advice from the hospital managers and clinical community, who said that we had just released a report, and we've released 2 in this area, about the length of time that people are spending in emergency departments across the country. For example, in major metropolitan hospitals across the country, anywhere from 30% of patients leave the emergency department in 4 hours, all the way up to 70% of patients. So huge variation, even just across major metro, but similar variation you see across regional in the percent of people who are staying in emergency departments for some time. Because of that, our clinicians were saying you could front load some of the costs into current emergency departments, so it wouldn't be fair to compare them across admitted patients. So we did undertake to do a bunch of work by taking admitted patients who had come through emergency department, linking their costs in both locations of care. So you had kind of a longitudinal measure for admitted patients that combines both their emergency department costs and their admitted patient costs, only to come to the conclusion that how you sort hospitals on relative efficiency is the same at the end of the day. But we didn't know that, even though Tony forecast it. Okay, so There are two graphics in the report that really summarize the results. This is the one that looks at the admitted patient in the ED, but essentially the graph and that distribution of variation of hospitals is similar across the two measures. Indeed, those hospitals that have among the highest costs in one measure are indeed the same as the other. What you see from this slide, it has got three different peer groups: major metro, major regional, and large hospitals, adding to some 80 to 90 hospitals across the country, is indeed that there is twofold variation. For example, you see in major metro between hospitals where the operational costs that are comparable across the country, which is the majority of operational costs, are twice as high for similar patients receiving similar types of services after we do our standardization based on the relative mix and collection of services provided across all hospitals. So there's one of our little infographic tweets that was sent out on the day when this report was released, as I mentioned about a month ago. One of the things that we spent a lot of time in with this report, given the advice of our stakeholder advisory, in particular clinicians, was that those overall numbers have so many determinants to them. Sometimes clinicians or hospital managers may feel kind of disengaged from what are the levers for improving relative efficiency. So why don't you, as their performance authority, release information for relative length of stay at the same time, and do this for 16 clinical conditions that a lot of people in healthcare and the public can relate to. So we selected 16 clinical conditions that are representative, actually, first of all, that represent the bulk of large DRGs that have a number of hospital bed days. So across the 16 represent about 10% of bed days nationally. They selected a mix of general medicine cases, a mix of surgical cases, and a mix of conditions that the public could relate to, for example, childbirth, appendicitis, gallbladder, those types of things. So a number of slides now that go through some of those 16 clinical conditions to show you the signals that we have from data from length of stay are signals that show us the variation in underlying costs, not necessarily that there's a direct relationship between length of stay and cost. So for example, vaginal delivery. If you look across average length of stay for a hospital, for women admitted for childbirth, 50,000 admissions in the country, average length of stay at the hospital level is between 2 and 3 in major metropolitan hospitals. What does that mean for costs? Vaginal deliveries for comparable costs of operational costs, not full costs, comparable costs for operational costs in the country range anywhere from $2,200 to $6,500. Right? Here's a tweet. Let's move on and look at surgical. Knee replacements, about 5,000 admissions across the country each year with no complications or comorbidities, major metropolitan, major regional. Variation in length of stay across 4 hospital peer groups, the graphic that's just on the right. For example, major metropolitan, anywhere from 3 to 8 days length of stay, 3 to 8, almost threefold variation in length of stay for hip replacements, major metropolitan hospitals. Clearly variations in models and approaches of delivering care across our hospitals. If you look at the average cost per admission across major metropolitan hospitals, operational costs comparable nationally, anywhere from $10,000 to $29,000. Knee replacements, on average, major metropolitan hospitals across the country, standardized for things like patient age, mix, DRGs, etc. Okay, we can go on and on for 16 conditions. Let's just show you complex condition, COPD, which, according to our national agreed approaches for potentially avoidable admissions to hospital, shouldn't even happen anyways, or could be lower potentially than they occur in terms of prevalence. 20,000 admissions for COPD, and indeed I know that those admissions vary across local areas by 5-fold in similar areas across the country from another report, and Healthy Communities report. This is COPDs without complications or comorbidities. What does variation in length of stay look like? Anywhere from 3 days to 6 days, major metropolitan hospital, 2-fold variation in length of stay. Major metropolitan hospitals, COPD patients. Now I can understand that at a patient level. This is a hospital average length of stay, 3 to 6, major metro. Variation in overall operating costs as they're comparable across hospitals, anywhere from 3 to 10. Cellulitis, same thing, considered potentially preventable in terms of being able to reduce these by better care in communities in the country. 23,000 admissions, variation in length of stay anywhere from 2 to 5.5. So more than 2-fold variation in length of stay across the country. What do costs look like? Anywhere from $1,900 to $7,400, hospital level comparable. Oh, but all those cases are kind of complex. So let's look simply now at a hospital level, length of stay cost variations for all the appendix removals done at each hospital across the country. Major metro, length of stay, 1.5 to 3. 2-fold variation, appendix, length of stay, major metropolitan hospitals. What does variation costs look like? In operational costs, anywhere from $4,600 to $10,000 per case. All right. There is not necessarily always a clear and direct relationship between length of stay and costs. We know that. We put that information together at the advice of our clinical leaders and hospital administrators. And the reason that they wanted us to do that is so that everyone working in hospitals know that they can have their hands on the levers of change that relates to patient outcomes and relates to efficiency. With all that variation between all of those conditions, those 16 clinical conditions, there's probably variation in outcomes. There's certainly variation in resource utilization. And even if the outcomes were all the same and all fantastic and all optimized at every single one of those hospitals, there are still differences in their resource utilization to attain those outcomes, okay? But all people and teams, clinicians in particular, have the hands on the levers for change, and that was why our advisory committees asked us to put that information together for clinicians. I put this slide up here because when we were doing the final graphics and final edits, this is something that we noticed in the report that we don't talk about in the report that I thought was quite interesting. We made all those graphs customized for length of stay for each of the conditions based on how long people were staying for each of the conditions. But when we looked at them more closely just before publication, what did we notice? Is that after those first couple of days when you were stabilizing general medicine people, or after you're getting the surgery done, so the height of the first bar, varies by the condition naturally. The incremental cost of each additional day after that was almost the same right across every single condition, anywhere from $900 to $1,100, comparable operational costs for each one of those patients, right? So those levers of change of being as a team in a clinical area in a hospital, even alteration of a day or two is very material. And if you multiplied that across conditions, across teams, and across hospitals in the country, we do have a lot of potential in our individual teams in our local hospitals to make a difference for patients in the area of efficiency while keeping our eye naturally, of course, on quality. So the intentions of the Performance and Authority and our work to customize information about health and care, information around access, quality, and efficiency, to be able to provide that to people in the primary care sector in the hospital has been underway for about 2.5 years now. And we've done that, as I've mentioned, in collaboration with other organizations, this instance with the Pricing Authority, and with the advice of the clinicians and health leaders and health managers in the country to create that information in such a way as to motivate, inform, and help focus improvement efforts in the country. As I mentioned earlier, more than 125, 130 measures of health and care in local communities, either at Medicare local level, soon to be cut and released for PHN level, as well as 300 units of geography, in some instances postcode information, for example, immunization, available on our My Healthy Communities website. Number of measures in health and care for more than 1,000 public and private hospitals on the My Hospitals website. Our most recent advancements in this website over the last 4 to 6 months or so has been in interactive tools. Interestingly enough to us, our interactive tools for that comparable cost report were used twice as often on the day of release as our report. So get in there and it's just a click away, interact with our website to have quick access to the information that you need to improve care in local communities. There we are.